My name's Claire Mathews. I'm one of two job share deputies that have just started to be the deputy head of maternity for NHS England, and we work directly under and with Jacqueline Dunkley-Bent, who I'm sure that you've all heard of. And I'm going to talk to you today really about the Maternity Transformation Programme and where we're up to now, and what's really going on, and to make sure that everybody, or as many people as possible in our profession, are aware of what is happening and what is going on out there in the system. So just to recap, and I'm sure that you all know, first of all, let's just have a quick show of hands. How many people have heard of Better Births? Gosh, now I actually thought the whole room would put their hands up, so I'm going to do it again just in case you were shy. How many people have heard of Better Births? That's better. Okay. So Better Births is the report that was published in April 2016, so we're just short of 2 years on. And that was the report into the maternity services review that was conducting following a lot of things that needed to be learned, particularly in and around the events that occurred at Morecambe Bay, which I'm sure you've all heard of. And quite quickly overnight, the maternity review and the Better Births publication turned into the Maternity Transformation Programme, which basically is a programme of work over a 5-year period to actually implement the findings and the recommendations of Better Births. So the vision for Better Births and for the Transformation Programme is that for all services across England, for them to become safer, more personalised, kinder, professional and more family-friendly. And I'm sure that most of you have heard this, seen this, because it's one that's used almost every time. Where every woman, and that's every woman, has access to information to enable her to make decisions about her care, and where she and her baby can access support that is centred around their individual needs and circumstances. And then for you, the next important bit is this bit. And that for all staff to be supported to deliver care which is women-centred, working in high-performing teams, in organisations which are well-led, and in cultures which promote innovation, continuous learning, and break down organisational boundaries. And hopefully, some of you, in some of your organisations, will have started to see that happening. So just a quick reminder, out of the report, there were 7 themes that came up. We had personalised care, safer care, continuity of carer, postnatal and perinatal mental health services, working across boundaries, multi-professional working, and a review of the payment system. The aim of the programme is to ensure that the vision and the recommendations of Better Births is implemented. So that's the aim of the Maternity Transformation Programme. And by doing that, and the way they're going to do that, is by supporting local health economies, which have all come together over the last couple of years, and earlier on, a few months ago, earlier on in 2017, we formulated local maternity systems. So each of you working out in your system will be a practitioner or a woman, if you're here as a mother as well, that have had a baby in the services, that is actually deemed and located around your geographical location. And ensuring that the delivery of the recommendations are aimed at national bodies, so that we actually get the support that we need and the resources appropriate to make these things happen and actually turn it into practice. The big one, and I'm going to say this several times, so if you don't take away much from today from me, you need to take this one away, and this is a really important one. And this is really to ensure that we support the Secretary of State's ambition to reduce the rate of stillbirths, neonatal deaths and brain injuries, commonly referred to as the Harvick campaign. And for anybody who doesn't know, the aim of the Harvick campaign is to have a 20% reduction by 2020 and a 50% reduction by 2025. It's just been brought forward because it was 2030 and it's now been brought forward to 2025. And the reason for that is it's believed that it's so important to make such a difference, and that actually the pace of delivery was doing so well and going so well across the country with the different initiatives, that actually it was felt that if we left it to 2030, then actually it may start to lose pace. And it is obviously important for every baby out there that we save, or every mum and baby that we provide that care for. So the values of the programme are that we make sure that safety is a thread through every part of the programme and everything that we do, that we put women and families and their babies at the centre of all the care that we provide. We seek to give babies the best start in life. We work on a multi-professional basis and across boundaries in a much different way than we have done before. And I don't mean working as a community midwife. Your lady today had her baby in your neighbouring unit, and tomorrow, because she lives in your postcode area, you go and provide that care. I mean really working across boundaries where you may actually transfer and provide care yourselves as a midwife throughout different parts of the service, including other trusts in your area. That we actually value our staff and recognise the contribution that they do and they bring to the improvement programme. That we listen and we build consensus across everything that we do. We share the best practice and we share it continuously as quickly as we can so that it can be implemented and it can be effectively rolled out and replicated. And that we learn very quickly from what doesn't work. But at least we've tried once we've done something and it didn't work, but we learn from it and we move on. And that we empower and support local change. So after the 7 work streams, recommendations that came out in Better Births, it turned into 9 work streams. There are 2 drivers, 4 enablers, and 3 service improvements within that. The 2 areas that are drivers are local transformation and the increasing of choice and personalisation, and they're seen in purple. The 4 enablers is about reviewing and transforming the workforce, looking at the data and the information and how best we share that information and ensure that we're comparing like for like all the way through, improving digital technology so that it enhances your work, but it actually also enhances care for women, and that women can access their digital records and the services quite easily, because most women are using technology nowadays. The payment system, so the bit that really gives a lot of senior managers in the organisations a lot of trauma, is there enough money in the pot? And then service improvements, safer care, thread through everything. Access to perinatal mental health and services, and there's a huge work stream on that, and prevention and public health. And the prevention and public health wasn't there in the initial stages, it came on a little bit later. So it's one of the less developed programmes, but it's actually picking up pace quite nicely. So the first one of the 9 is the local transformation and supporting local transformation. And as an unbiased person working within the whole of the system, I'm going to share with you that I think this is the biggest work stream. I'm sure that everybody who works on each of the work streams thinks theirs is the biggest, but this is a really big, meaty piece of work that's going on. So across the country, there are 7 early adopters, and the early adopters have been tasked with going further, faster, and at pace, and implementing the recommendations of Better Births as quickly as possible. And there are 2 early adopters in the London region, for sure, and actually there are only 2 particularly in the north, so actually they're all more or less the south of England. One of the big things which I've already hinted on was the formation of the local maternity systems. So that is where all the different providers within a geographical location come together with a shared governance structure to try and improve services with shared trajectories and shared ambitions across the services to try and make things better for the women and the babies and the families that we care for. And as of last summer, there were 44 that were actually set up. They've all been busy writing their plans and submitting their trajectories, and the second iteration of the plan went in at the end of January. So some of that work is going to be starting to come to fruition quite quickly. Another big piece of work there is the development of community hubs, where actually wraparound services are available for women throughout the whole part of the continuum of their pregnancy, and to ensure that all services come to them rather than women going to different areas at different times for the care that they require. Continuity of carer, and so we've just had the implementation guidance that was published in December of last year, and there is a lot of controversy at times about whether what the standpoint is on continuity of care. However, the research and the evidence is overwhelming, and particularly overwhelming for vulnerable groups, that the outcomes of continuity of care models for women have such high improved outcomes that it's something that we can't ignore. And it's what the women asked for, so that's one of the key drivers. There's just recently been a postnatal expert reference group set up, so that's a new piece of work that's just in the pipeline in the last few months and starting to be developed. And another huge important, which is about breaking down the boundaries and working differently, is the choice conversation, so that women are really given a true choice about where they have their baby. And by that, I don't just mean in the community or in the home or at the hospital, but actually, if it is a hospital, which hospital? And that is not just the one that I work at, because that's what I'm going to advocate today, but actually we're in a shared system in our LMS, and we're going to openly advocate all services, and that the women can have an unbiased choice about where she goes for her care. And that's one that can be challenging for individual trusts at times. And the big thing at the end, really, on the bottom there, is to ensure that service users are involved in everything that we do, and that they're part of the co-design process, and that maternity voice partnerships, I'm sure you've heard of, are really coming into their own. MSLCs in some places are still around, but in places where they were not as quite successful, MVPs are coming up and really making a difference and really getting co-design in there. The next one is service improvement, which is around the safer care. So it's a service improvement one. And the big thing really there is about the widespread dissemination and adoption of best practice. And so I'm going to say it again, just in case you've forgotten, that one of the real key drivers where it all started and where we really aim for is the Harvard campaign, so reducing the number of stillbirths, neonatal deaths, maternal deaths, and interpartum brain injuries. Another big piece of this work is around multidisciplinary training, and it's not just about paying lip service to multidisciplinary training, it's about ensuring that all multidisciplinary members of the team are in the room and training together, and not just one-off once when the junior doctor rotation takes place, and not just the midwives, but everybody, the anaesthetists, the obstetricians, the maternity support workers, the midwives, and anybody else who's vital in that care pathway. And a really big piece of work here is around health education, really helping to support and design how that will look. Another element is the Saving Babies Live Care Bundle, and making sure that all organisations in the country sign up to and implement all 4 elements of the Saving Babies Live Care Bundle. And that will actually impact directly on the Harvard campaign and the figures and the ability to achieve. And then lastly, for this area, particularly is around the rapid redress and resolution. And you may or may not be aware that just in the last couple of months, there's the development of the Health and Safety Investigation branch into the new way of looking at all intrapartum stillbirths. So organisations will not be looking at these themselves in the future. There will be a support network throughout the country that will help organisations to ensure that unbiased learning is occurred and that it's shared and implemented widely. Workstream 3 is increasing choice and personalisation. And the big thing here is about deepening and widening choice. And you'll start to realise as I talk it through that they all interlink all the way through. So the big thing about this, which I picked up in the first work stream, is about working across those boundaries and about really deepening and working across and not actually being constrained by your own organisation. So there are 7 pioneers in the country that again have been chosen to go further, faster, and to implement the recommendations, particularly around choice and personalisation. Out of the 7 pioneers and the 7 early adopters, there are 2 areas in the country that have actually been awarded both status, and that is in Birmingham and in Cheshire and Merseyside, and they are the only 2 places in the country that are working on both work streams at the same time. At the end of the financial year, we are hoping to have achieved 10,000 personalised maternity care budgets, or at least have the women on that pathway where they've had a discussion and a choice conversation about where they have their baby, which team, and where they want to have it in the community, in a hospital, or whether it's the hospital that's local to you or not. The other thing that the pioneers are doing is they're baselining the current process, because one of the things that we've heard as we've done a lot of this work is that we already provide choice. Women can already choose between providers. So we're baselining it, and we're actually going to map it out and benchmark exactly what is going, so that we can actually tell you what improvement has been made in the future. And another one which is really important is about the development of the new entrants to the market. So the two areas that are particularly high profile is one-to-one on the Wirral and neighbourhood midwives in and around London, and about ensuring that they are able to practice, that women are able to make those choices, and that they are safe and supported in that market, and that they're sustainable. The next one is perinatal mental health. And the big thing here really is about access to perinatal mental health services being closer to the home and when women need it. And this is probably one of the areas that's been really lacking. And just approximately a year ago, there was an announcement of £290 million that was going in to actually improve the perinatal mental health services, the specialist caseloading teams across the communities. I thought that was a lot of money, but apparently that's a tiny drop in the ocean. The other thing for this is to ensure that we get evidence-based pathways, and the great news is that there are going to be 4 new mother and baby units in the country. And I know that's not a lot, but it's 4 more than we already had. Workstream 5, which is around the workforce, it's about having the right staff in the right place at the right time with the right skills. And the real big thing here is mapping and working out how many of each workforce group do we have, how many do we need, what model will it be, and how much will it cost. And then when we have all that information, how do we make that happen? I can't forget on this slide, even though I've been told I've only got a few minutes left, I have to mention AEQIP. Has everybody in the room, hands up, anybody who has heard of AEQIP? Okay. Does anybody, how many in the room know about a PMA? A professional midwifery advocate? Okay. So AEQIP is the model that is being, it's an employer-led model that has been implemented in the place to support midwives and organisations in the place of supervision of midwifery. So we know that we don't have statutory supervision anymore. If you need any more information about that, because I haven't got very much time, come and see me afterwards, or ask when we're on the stand. The next one, Workstream 6, which is sharing data and information. And the real big thing here is making sure that the information that we have drives the quality improvements, and that we are mapping apples with apples. So what a birth looks like, a normal birth in your unit, is the same as a normal birth in that unit. So for example, a really easy way to capture that is, this unit might say a normal birth was a lady who had a vaginal delivery with an epidural in lithotomy. But that one in that unit might be a normal birth with no analgesia, on all fours on the floor on a mat. Is it the same? That's up for debate, isn't it? But making sure that we actually get that same information across everywhere. Workstream 7 is the digital technology, and making sure that all women have access to their digital maternity record, and that midwives have access to the digital maternity record, and that they have the ability to share information. This is quite a big work stream, and it's going to take 4 or 5 years to complete. And the biggest issue with this one is about the interoperability, because once the digital technology record has been developed, it needs to be able to be used when you work in a GP surgery, when you work in a woman's home, when you work in your organisation, and when you go to another organisation. So portals all need to work together. So we don't have to say that organisation has to change their information system to match that one so that they read across, actually making the link behind the scenes for that to happen. Reforming the payment system, quite controversial in that we all know that there's not enough money in the system for maternity services, or anybody who works at a senior management level will definitely say that. And the big thing here is really making sure that we have the appropriate amount of funding to ensure that services are safe and efficient. And the work that needs to go on there to inform this is the more information around postnatal care, continuity of carer, perinatal mental health, and the personalised maternity care budgets. And without all that background information, they can't really change that tariff very much. Lastly, on the work streams, it's the prevention. So this is all the full public health agenda I'm sure that you're all aware of about preventing poor outcomes. So big piece of work here is about developing a programme plan, which is going to be a visual pathway to ensure that we're all working in a similar way with the same agenda to reduce smoking, to improve outcomes for women with substance misuse, domestic abuse, making sure that they're taking, or they're at least aware of what screening is available and the choices and the reasons and the rationale why, immunisations, breastfeeding, teenage pregnancy, asylum seekers, whatever, we can go on forever. And then my very last slide really is just to bring together some of those really key things, which is to say, again, the Harvick campaign to reduce the stillbirth, neonatal death, maternal death and interpartum brain injuries by 20% by 2020 and 50% by 2025. And I'm sure that you will all remember that before you go home. Another big target is choice of place of birth, and these are really quite, for me, I feel really strongly, I'm very passionate about these targets, to increase the home birth rate nationally from 2% to 4% by 2020. To reduce the amount of births in a freestanding midwifery-led unit from 2% to 4% by 2020, and to increase the number of births in an alongside midwifery unit from 9% to 20% again by 2020. And then just came online just in the last 2 weeks, the target trajectory has been set to ensure that all women have access to a continuity of care, a pathway, if and where appropriate, and to have 20% on those pathways by 2020. The nice thing I can share with you as part of an early adopter and as part of a pioneer is that there is a new freestanding, fully operational birth centre just on the outskirts of Bolton, which is going to be opened in April, and that's called Ingleside Birth Centre. And then in Cheshire and Merseyside on the Wirral, there is a freestanding pop-up birth centre to test the feasibility and the concept in that area, because in that area they don't have any. So immediately in those areas, the chances of freestanding birth is going to go up because they don't have any. So they're at 0% at the moment, so they have to go from 0 to try and get towards 4. So those 2 new units are going to really help with that statistic. And that's me for today. Thank you very much.